Don't you love the topic? He came up with that. Well, I didn't draw this. Actually, this drawing is from my sister. I was telling her about my topic, don't poo-poo the robot. So she came up with this. I'm like, I'm going to use it. She's like, you're not. I'm like, I am. So anyway, let's talk about colons. These are my disclosures. I do love the robot, and I do think it will open up a lot of pathway of cases that you want to do at your institution. So talking about emergency for colorectal specifically, is it a right tool? Like when someone comes with a large bowel obstruction, perforation, bleeding, should we start with a robot? And the question is, how should we plan these cases? It's not just the surgeon. You got your whole team that you got to get involved. And we're going to talk about how to get everyone, involved. So some of the cases, as we all know, like what comes to us, bowel obstruction, bowel perforation, hemorrhage, some of our inflammatory bowel disease, with their problem, and also malignant diseases. So pros and cons, I think all of us by now know, being in this room, what are some of the pros of doing things minimal invasively, and what are the cons? For the robot specifically, less pain, decreased hernia rate. Sorry guys, no hernias for you. Shorter length of stay, less surgeon fatigue, and wound infections, and there are cons. Well, if they're saying, well, it's increased cost. You take so long on the robot, or the availability, like we talked about right now. Access, after hours, weekends, and your OR team. Are they really aligned with you or not? So, what's the data? I'm not really going to go to the data. I would like to mostly show you guys, some of the cases and how you get, prepared for it. But there's been multiple studies, systemic review, meta-analysis, retrospective, you name it. I just put a couple here. You can look it up. Mostly it's comparing laparoscopic to, open, and not much on the robotic. But, all the studies say that laparoscopic approach, which is a minimal invasive approach, is safe in an experienced surgeon, and you have to have sufficient resources. So we're going to advance that to the robot, and actually we just wrote a paper, and hopefully will be published soon on our emergent cases. Now, how do you integrate that? I truly think you need to have some laparoscopic skills. Because you put that scope, like we talked about in emergency cases, put a scope, see if it's possible or not. So sometimes in a lot of cases when, as colorectal, or even general, any field you go in and it's a disaster, and I'll show you that. You have to have some laparoscopic skills to take those adhesions to some extent down to put your ports in. So you gotta have that. You have to pass that learning curve. You can't start with doing one API robot and then jump to emergent cases. It's a pathway. You gotta get comfortable with that. So you gotta go past that learning curve. And do more complex cases and then add those emergent and urgent cases. And it's not a one-man or woman show. So it's not just you, it's your team. You have to communicate with your team. You have to communicate with your anesthesiologist, with your PA, with your resident, with whoever is working with the surgical tech. So everyone has to be aligned. And, it's really important in these acute cases, you have to preoperatively plan for it, even though you may not have that much time. Intra-op, what you do, and also, of course, your post-operative care. So all the things we talked about, and make sure to do a safe operation. And conversion is not a failure. So I know we're talking robots here, but if it's not possible, do what's safe for your patient. And then also, we're talking about the enhanced recovery afterwards. So I made this acronym for kind of complex urgent cases, and you can actually put that on for, emergent cases. It's SEATS. And the way it is, the S stands for your patient selection. Not everyone may be a candidate for going, doing it robotically. Evaluate that patient. Is it possible or not? What is going to be your access? What is going to be your approach? Avoid, any injury. Be safe for it. And then the tools you have, and ultimately safe operation. So access, you have your choice. I personally use, if I have a bowel obstruction or a patient who had multiple surgeries, I like to use the OptiView. I enter from a palmer's point and left upper quadrant. If they had left like a splenectomy in the past or incision there, I go from the right upper quadrant area. But port placement, you can choose what you like. And I personally like to see the CAT scan before, taking the patient to kind of have an idea where I'm going to access. So this is a patient I had, I'm not kidding you, 22 operation. She had a bariatric surgery, unfortunately got complicated with a leak, surgery after surgery, open belly, ICU. So this is, and the reason I put this picture, you see she has a huge ventral hernia. The reason she came to us was really bad diverticular disease, but also bleeding. So the bleeding was the main factor we ultimately had to go in. And you see I placed 2 extra ports. Usually my port placement for low anterior resection starts from right lower quadrant to left upper quadrant, straight line. But playing this hopefully. So when I entered in that left upper quadrant, I couldn't see. I mean, she had multiple surgery and she had a huge mesh on the anterior abdominal wall. So really can't see. So what did I do? Place a 5 millimeter port. It's not gonna hurt the patient. So put a 5 millimeter port in the left lower quadrant because that was the only spot I could see and started taking down. You see I'm pushing on that hernia to get the bowel down and kind of sweeping with your, you can use your energy device, what's comfortable. Get, at least to some extent, the bowel down so you can place your ports for the robot. That's why I think having some laparoscopic skills, it's important. So here I'm, placing the rest of the ports. I use the bariatric, actually the tall ports, to kind of have more room on an area that has a hernia. I think it really helps. This person had a mesh. You see the bowel is kind of like stuck to the mesh. So taking it down, believe it or not, it's been 30 days she's out. She has not come in, and we have not made any enterotomies or fistulas or anything like that. I think you have to use the heat very carefully. You see, I don't grab the valve very much, and I think this is one of the techniques in these emergent cases want to tell you. It's more pulling away or even just opening the jaws very slightly, just touching the bowel, pulling it down to give you a little tension. So that tension, counter tension, and with a robot is nice because you can really, achieve that with just pulling with your instruments of choice. But you see, mainly, I try to do a kind of a less touching, grabbing technique and taking this. And we had, honestly, 0 enterotomies or anything like that. And the previous surgery that she had apparently, based on the operative report, 6 enterotomies. So it's what you use. Use the tools in your toolbox. ICG, it's a great tool, in really bad cases that you go in. So put the, ureteral stent. You even don't have to put the ureteral stent. Put 3 cc to 4 cc ICG and then flush it. You can cap the stents, take it out, or just put it in the ureteral orifice. This video is mostly kind of talking about team approach because I think team approach is really important. So this was a lady, she was 32 years old, she was 28 weeks pregnant. So, uterus is pretty big. She came in with a partially obstructed rectosigmoid cancer. We tried every single instrument to hold this uterus up. And I really didn't want to do an open operation for her. I thought if we can do this minimally. You see, that's the uterus sitting there. So I communicated with my bedside assist. I said, let's put a hand port in the lower abdomen and use your hand as an assist port to pull this uterus up so I can work. So as you guys see, I did the sigmoid colectomy. Based on that, it's a tough spot there, but it's a trust between your assistant, the surgeon, the surgical tech, because her hand is there. I'm using energy device, I'm using needle. So you gotta be really cautious, but also you have those plans. Okay, like what are we gonna do next? And she left actually less than 2 days from the hospital. The only reason she stayed was for monitoring, the baby. And I gave her a colostomy just based on the location. I couldn't put the anastomosis on a large uterus over, but she did fantastic and ultimately went home. So these are kind of some of the team approach. Intra-op, how do you plan for it? So instruments that, I like to use usually is my monopolar scissor, atraumatic, grasper. You can use, be ready with things, use your envelope. Here you see I injected ICG to the ureters because it was stuck. So this was an anastomotic leak that was, kind of chronic. We watched it with drains and everything. You see the small bowel is kind of stuck to that pelvic wall, everything kind of like together. So here I knew I have to put a stent because I want to do a safe operation, and also I want to be efficient. I don't want to be looking for the ureter 10,000 hours, right? So you see here everything is kind of stuck, but kind of using all instruments, and your assistant is constantly working with you, is using that suction, coming in when it's needed. You can use actually robotic suction if you want to, but in this case, you see I have like all 3 arms working, finding the area, where that ureter is, and starting from an area that is less of a disease and moving downwards, getting exposure for myself. So here, and then vessel sealer is a great, energy device that, in cases that is really kind of things bloody and friable, good to use. This is another lady with history of diabetes, hypertension, perforated diverticulitis with a tubo-ovarian abscess came in. You see the small bowel was kind of stuck. Here's that abscess cavity. We have, again, all 3 arms working together, appendixes, but you're paying attention that I'm not grabbing bowel as much. It's more of like pulling things up, sweeping, kind of using the side edge of my instruments to kind of get to these, abscess cavities and these friable tissues. And, the assistant is there. It's like, is there's gonna be abscess, pus, poop, whatever it is there, to take it out here. And she's kind of ready, draining all of that from that tubo-ovarian abscess where it's located. And then ultimately, once we've washed it out and cleared out, we'll staple it, and I place the drain in her pelvis. But here, use all you can use, I like the cigars, we call it, a little like a loop, a gauze, or you can just use, regular 4x4 gauze, and it helps, with the visualization. Sometimes when it gets too bloody, the visualization is not great. So any of those, either the little cigars or the gauze would be, very helpful in these cases. So that's where, and she actually did very well. I think she stayed like 2-3 days. We gave her some IV antibiotic and left. Here's another scenario, as colorectal surgeons, you'll get these patients. This was a very sad story. 29-year-old came in with an obstruction. So here you see I put 1 port in, trying to figure out, there's tumor everywhere, obstructed, carcinomatosis. And I think what I want to show is like, that entrance, kind of be, I had to change my port placement from what I usually do, trying to figure out what. But here you see, again, I'm emphasizing, don't keep grabbing the bowel in these scenarios. It's dilated. You can rip it. And that's how the poop comes out. And I guess this talk is about avoid getting there. So, kind of try to use your arms kind of to sweep up and use 2 arms to separate the tissues for you. And here you see I'm pulling without, grabbing, just getting under and pulling the bowel up. And eventually I had no room. I had to bring unfortunately, the transverse colon up because she just, there was no give in this case. But ultimately she did very well, at least her obstruction, so she got to her chemotherapy. This was a 50-year-old gentleman, very weird presentation. He was diabetic. Unfortunately, he was, had partial obstruction from his cancer, and he was COVID positive. And now we're just operating on these COVID, and I don't know if that was the case or what. But anyway, post-update 13, he comes in with this kind of a severe abdominal pain, very weird presentation. His CAT scan showed free air and fluid. So here again, you see I'm kind of sweeping, even with the scissor, monopolar scissor. I'm not pointing. I'm using the side of the scissor and making the cuts, and very smooth moves, pulling all these kind of adhesions, all this phlegmon, down, because this is, you can see, it's really easy to kind of rip off the bowel in these cases. So use the side of your instrument, when you're using your bipolar or monopolar scissor, and get things, kind of sweep things downwards. And in this case, apparently he was with us for like 13, 14 days and came to us. So weird, he had like abscess cavity and purulent material all over. So we suction everything out, and you see the anastomosis is actually to that side of it, which looked intact. But he had a lot of fecalith material, kind of like more like a bilious material above the liver and in the lower abdomen. And you see at one point, I couldn't control with just the regular laparoscopic. My assistant couldn't kind of keep up. You'll see it once we get. So I had to open up the robotic. So use the tools that you have, and it was great. I used my non-dominant arm kind of to sweep and also suction all that fluid, and I use my dominant arm to, get all of that adhesions down and get all that pus material out. And he, unfortunately, next to our anastomosis, the bowel next to it, there was a hole in the small bowel that we found in this case, and we closed it with Vicryl in 2 layers and placed multiple drains. His course was a little longer in the hospital, just he was sicker, so we had to optimize him, but he ultimately did well. So I guess the key point in these cases, you know, how you handle the bowel is very important, and robot is a great tool to allow you to do of a less traumatic touch in these cases. And this is, I think, our last kind of showing the anastomosis that you can do intraoperatively. So this is a bowel obstruction after my APR. The small bowel got stuck in the pelvis. Again, you see very smooth moves, you know, pulling the bowel out, getting access. There's a loop of that small bowel down in the pelvis with all of that pus material kind of there. And here, my assistant is with me, is ready, you know, suctioning. You see, I use the side and kind of sweeping with the vessel sealer. And then once I feel that it's safe and I don't have the bowel, that's when I, you know, separate it. Here, as you can see, it's not a very healthy bowel, so I'm like, well, with the same port placement, I was actually able to do a small bowel resection. You know, I like to play those stay sutures because it keeps things, number one, I can move it away from myself, so my ports are not in a place that I usually do this surgery, but if you take things away from yourself, you open up space for yours. And that's where I can, you know, I made 2 enterotomies. I like to dilate first and then place the robotic stapler. But you see, I move that the bowel kind of away so I can get my right lower quadrant port in to do the suturing. So, and ultimately, she did fantastic. She actually left, I think, day 2 or something from the hospital. So, in conclusion, is it possible? Yes, you can do emergency cases, you know, but in a right patient setting, you gotta have that team, you know, you gotta talk preoperatively with everyone, especially with your assistant who's at the bedside. But it's not a one-night thing. It's a special training. You gotta, you know, go step by step, like how we do in surgery in any cases. And you're able to do things minimally invasively that we weren't able to do in the past. So don't poo-poo the robot.